pleural effusion is fluid where? In this pleural space. Okay? You got fluid buildup in the pleural space here. All right, does that make sense? Pleural edema here is little alveoli. Okay, you got fluid buildup here, and it can even move into here. Okay? That makes it. You understand the difference there. All right. Some of the causes of pleural effusion can be heart failure, TB, neoplastic tumors, pulmonary embolism, and then also connective tissue disease. All right. The normal pleural space should have between 5 to 15 milliliters of fluid. Okay. Usually a lubricant type substance, not just fluid. All right. So 5 to 15. If you have more than that, if you have a buildup of fluid there, that's when we consider the patient to have pleural effusion. All right, some of the manifestations. Well, patient will have clear, bloody, or purulent sputum. And then also, what was the one that we talked about a while ago? What else is going to happen? Same with pleurisy. Pain when? Pleuritic pain, so pain during that breathing cycle. All right. Now, transudate. Does anybody have an idea on what a transudate is? Well, I can tell you. That's good. Probably the opposite of exudate. Yeah. All right. Transudate is going to be an ultrafiltrate of plasma in the pleural or pleura due to abnormalities of hydrostatic or osmotic pressures. Okay. Exudate, on the other hand, they arise from pleural or lung inflammation, impaired lymphatic drainage, also transdiaphragmatic movement of the inflammatory fluid from the pleural space, and also altered permeability of the pleural membranes. Okay. All right. Here's what you need to know. Okay. We're going to break it down. Here's what you need to know. All right. Transudates, they're going to form with CHF and also hypoalbuminemia, which occurs with starving patients that are malnourished or they have cirrhosis. Okay. CHF and hypoalbuminemia. Okay. Yeah. All right. So transudate is going to be ultrafiltrates in the plasma in the pleura due to abnormalities. Maybe this helps some too. All right. This is pleural effusion. Okay. We've got movement of fluid, or well, a buildup of fluid here. Okay. This is a look at, we'll talk about pneumothorax in a minute. This is the difference. A pneumothorax, what's happening here? The lung has collapsed. So there's nowhere for air to move into. Pleural effusion, we've got the fluid, well, I mean, we got the space. We've just got fluid that's making it struggle to expand and contract. Okay? All right. Some of the manifestations. We'll talk about a few of these. Dyspnea. What's dyspnea? There you go. I'm going to hammer it home before too long. Dyspnea, difficulty or labored breathing. Pleuritic chest pain. We talked about pleuritic chest pain. What's that? Pain during that breathing cycle. Decreased or absent breath sounds. Okay? Now what is that similar to? That's similar to the pneumothorax. Okay? Usually you're going to have some crackles along with it, but it can have the decrease, usually decreased, sometimes absent. That just kind of depends on how much space this fluid is taking up. Diagnostic findings include tracheal deviation, chest x-ray, chest CT, and then thoracentesis is going to confirm diagnosis. It confirms that we've got a buildup of fluid and what the fluid is made of. Where's it coming from? Okay. And then the thoracentesis is going to allow us to do this pleural fluid analysis. Another type of diagnostic testing that can be done is a pleural biopsy. When they actually go in and take a piece they can analyze it and see what's going on with it. All right. So our treatment, pleural effusion treatment. Well, you got to diagnose it first, figure out that the issue is there. So the thoracentesis and the biopsy, I would also add that as well. Usually thoracentesis is going to be your initial diagnostic. With the pleural fluid analysis, all right, we've also got pleurodesis. Pleurodesis is when we're basically going to do chemical analysis. Chemical is done to obliterate the pleural space and prevent reaccumulation of the fluid. So we take away the ability for that fluid to move into the pleural space. Okay, so that's the treatment option there. All right, so chemical treatment done to obliterate the pleural space and prevent reaccumulation of fluid. This is performed via thoracoscopic biolomycin, or well, thoracoscopic procedure, and then biomycin, BLEOMYCIN, or tetracycline is going to be the chemical agent that's used for this procedure. All right, pleurodesis. It's basically we are treating the pleural effusion chemically to eliminate that pleural space, okay, or at least damage it to where it's not going to be able to accumulate fluid. Okay, so all right, we've got our lung here. Okay. They're going to use chemicals to eliminate some or all of that outer membrane. Okay, so if you don't have the cavity, you can't collect fluid, right? So you remove that collection of fluid there. Probably not going to be their first option. Right. It takes away that outer membrane that's collecting fluid. Okay. Well, it's chemicals. But tetracycline is one of the chemicals that is used. Okay, it's going to be direct administration. It's not like we're taking it orally. It's not like we're taking it by IV. This is a direct administration, and that is used to eliminate part of the outer membrane there. Yes. Yes. Performed. Trying to think back where I would have said performed. Oh, thoracoscopic. It's done by thoracoscopy. Okay. Thoracoscopy. All right. So let's hang in here. Now, now, we've also got chest tubes. Okay, chest tubes can also be used to perform this procedure as well. They can actually instill the chemicals in through the chest tube. Okay, and where's the chest tube going in? Chest tube going in to that pleural space, right? So it's going to go into that pleural space to allow for that re-expansion. Okay. In this case, they could instill the chemicals by the chest tube, via chest tube, okay, and then just clamp off the chest tube for an hour or so. It's still going to be infusion of those chemicals inside that pleural space. We're kind of getting too far in, I think. You know. Well, yes, you could, but they're looking for long-term correction of the issue. This is going to be a patient that has pleural effusion constantly. They can't get it under control. So they go in and actually damage that pleural space, pleural membrane, which collects the fluid. Again, these are things, the treatment options you kind of need to be aware of, but as far as the patho of them, we're not going to have to decide which options to use, right? As nurses, this is not something we're going to have to decide on. Well, I mean, you think about it. It's a double membrane, right? And I don't know that you're not going to have it. You're just going to eliminate that collection of fluid there. So it is going to damage it. It's probably going to basically make a hole in it. Yeah. It's just, that fluid would just drain off. Okay. It would just drain off into the chest cavity. It would be similar to a patient. Well, not necessarily similar to a patient that doesn't have a lung, but a patient that does not. They do a pneumonectomy and they remove that lung. You're going to have fluid that builds up in that cavity. And we'll talk about that, I think, a little bit later. But a lot of times they'll actually have that patient lay to where they're going to fill that cavity with fluid to build that space up so it's not completely collapsed. All right. Again, I think we're kind of moving too far off into this, but good question. You need to know pleural effusion. You need to know the symptoms. You need to know what it is, and you need to know how to take care of a patient that has a pleural effusion. Okay? You need to be aware of some of these treatments. You don't necessarily need to know step by step what are we going to do for a pleurodesis, because you're not going to be doing it. Okay? You need to be familiar with it, and then you need to know how to take care of a patient following the procedure. Okay? Yeah, so I mean that's not just with pleural. That's with all of this stuff, right? You know, we're not going to be in surgery performing the procedure, so we don't need to know step by step what needs to be done, you know, at each point. But you do need to know what it is so that you can take care of them post-op. All right. Now you've also got the pleuroperitoneal shunt. Okay, what's the peritoneum? Peritoneum's the stomach area, right? Yeah, I mean, that's the stomach cavity. Okay, a pleuroperitoneal shunt. What do you think that might be? There you go. It drains the fluid from here. That's your diaphragm. It's a shunt. Okay, that drains fluid from here into peritoneal cavity. Okay? Yeah. They're going to be two catheters, and they do connect them by pump to do that pumping process or the drainage process. You just need to know what it is. Drains the fluid from the pleural space into the peritoneal cavity. Okay? Well, not necessarily. I mean, you can have buildup, but it's not going to be that much of a buildup of fluid there. You know, our body can filter out that much fluid in through the kidneys. Okay? Well, we can get it out. Okay? All right. Again, I don't want to get too far into some of this, but so what do you think one of the big issues is going to be for this patient with pleural effusion? Okay, breathing, 100%. Probably going to be your number one, right? Okay, this isn't necessarily an airway problem, but it's a what? It's a breathing problem. Okay, what else? Circulation. Yeah. Because if we don't have that breathing, we can't get the circulation out, right? Okay. What else? Could have some GI upset. Likely, you're probably not. I mean, with this, a pleuroperitoneal shunt, probably not going to have that much fluid. But, you know. Okay. Any others? Pain. Big time. Big time pain. Okay. You know, after the breathing, that's probably going to be your next issue. It's pain. Especially if they've gone in for some of these procedures. All right. So, there we go. We're going to look at pain here. Pain infusion pump may be used. They may go in and do a thoracic epidural block, intercostal nerve block. Just depends on where the location of the pain is. But they may go in and take away some of that pain there, with analgesic blocks. Intermittent analgesics is just your POs, your IV pain medicines that we would give on a kind of a PRN basis. And then they may actually go in to the interpleural space and do administration of opioids. All right, now let's talk about chest trauma. Chest injuries are responsible for approximately 25% of traumatic deaths in the U.S. each year. What do you think this is likely caused by? Car wrecks. Going to be your number one most common cause. Most can be treated with basic resuscitation, intubation, and or chest tube placement. Some may also require thoracotomy. We'll talk about thoracotomies, but thoracotomy is just an incision into that pleural space. Okay. Now, the key thing to remember, the first emergency approach to all chest injuries is what? ABCs. Airway, breathing, circulation. Number one issue related to chest injuries, obviously. Airway, breathing, circulation. Followed by rapid assessment and treatment of life-threatening conditions. Some of the different chest traumas that we may encounter. First, we've got a sternal and rib fracture. Rib fractures are the most common type of chest trauma. Most are benign, but can be life-threatening. All right, the 5th through the 9th is the most common site, okay, of the ribs. The 5th through 9th rib, or intercostal space, are going to be the most common locations for these injuries. They usually heal in 3 to 6 weeks, and conservative treatment with pain control, avoidance of excessive activity, deep breathing exercises, rib belts may be used, and surgery may be used if there's a gross deformity. Again, it just kind of depends on the location and the severity of the fracture. All right, it's a big one, pneumothorax. Okay, pneumothorax. And what is a pneumothorax? Collapsed lung. And we've talked about this a little bit so far, but now we're going to kind of go into it in depth. Pneumothorax can be a condition, okay? Obviously, it's a condition, but it's commonly a side effect or a manifestation of something else as well. The most common direct cause of a pneumothorax is chest injury. Blunt force trauma to the chest, or the complication of a medical procedure. The reason we have a lung collapse is we have air that enters into the pleural space, results in a rise in chest pressure and a reduction in vital capacity. Basically, if we have pressure greater, if the pressure outside of the lung is greater than the pressure inside the lung, that's when we have a collapse. Okay? Think of it as a balloon. If we're going to go blow up a balloon, what are we doing? We're putting air in, which builds up the pressure. That's why we have it blow up. What happens if we have a leak? Maybe a small leak. It just kind of slowly starts to deflate. The air comes out, and what happens? Yeah, nothing's coming back in. So we have a depletion of the pressure inside of the balloon from the leak, and eventually, when we have enough pressure, enough pressure that's removed from the inside of the balloon, what happens? Collapses back down, right? Same thing. We want to keep it blown up to where the intrapleural pressure or intra-lung pressure is greater than the outside pressure being placed on the lung. So pressure inside the lung has to be greater than the pressure outside the lung, or it will collapse. Okay. We've also got a tension pneumothorax. A tension pneumothorax is usually the result of blunt force trauma, which results in an air leak in the lung of the chest wall. In the lung chest wall. I think it's supposed to be or. Doesn't look right. Lung or chest wall. Air is forced into the chest cavity. That's the problem. We've got some kind of fracture, or we've got some kind of outer hole in the chest wall that causes the pressure to move in. So we've got to build up a pressure being placed on the actual lung itself. So when air is forced in the chest cavity, it causes the collapse of the affected lung, and then air that enters the pleural space during inspiration, and then it does not leave during expiration. This air pressure compresses the blood vessels and limits blood return. So now we've got not only a breathing issue, but what else do we have? A circulation issue. Because we're putting extra pressure on the vessels that are returning blood back to the heart and into the lung. All right, this air pressure compresses the blood vessels, limits blood return back to the heart, and leads to decreased cardiac output. So now we got a cardiac issue. It is life-threatening if not recognized, and treated quickly with insertion of a large bore needle to relieve the pressure. So we've got to find some way to remove the air from out here in this chest cavity. Okay. And then eventually, hopefully immediately, placement of the chest tube for lung re-expansion. In the field, maybe a paramedic or even a nurse, more likely you're not going to have to worry about this. But in the field, if it's recognized that the patient has a tension pneumothorax, they're going to put some kind of, they do an incision, most likely they're not going to do an incision, but they have to put something there to relieve that pressure. So if they put a needle or they put some kind of incision in place to allow for that air to escape, the dressing they're going to use, what kind of dressing do you think they're going to use? Think it's going to be occlusive? No. We don't want it to be occlusive. Why? Because that's keeping that pressure in, right? We want the pressure to be relieved. So the dressing they're going to put on, what do you think it would be? Three-sided dressing. There you go. So they're going to have some type of dressing, usually gauze tape, but they're going to have that fourth side open. Okay? Have it open so that it allows for that pressure and that extra air to be released. Okay? The key is they have to open up that cavity to be able to allow that cavity or that pressure to come off of off of that cavity, I guess. Just off of removal of that pressure from the lung. All right. So here's a look at this. Okay. This is we've got the pneumothorax. This is the mediastinal shift. Okay. And as you look here, the pressure is placed on the lung. The outer pressure is placed on the lung, and it causes everything to shift over. And this is not just this lung here. I mean, this is not just the lung that's collapsed, where the pneumothorax has occurred, but also look what else is shifted over. The trachea. The heart will adjust some too. When this heart shifts over, what is it going to do? Where is it going to put pressure on? It's going to put pressure on the good lung. Okay? So sometimes they'll even have impaired breathing on the opposite side of the pneumothorax as well. Not near as pronounced as the affected side, obviously, but there will be some pressure here as well. Everything shifts over. Okay? So what do you think one of the manifestations is going to be? If you walk into the room and your patient has a pneumothorax, okay, wheezing and shortness of breath, sure. Okay, when you listen, what are you going to hear? No breath sounds on which side? The affected side. What else? Okay, could be crackles or rails on the other, sure. What else though? Pain. Okay, pain where? On the affected side. Okay, you're going to have pain on the affected side. And what related to this? If I look at my patient, what am I going to see? Well, cyanosis, sure. But related to this mediastinal shift, the trachea will deviate to where? To the unaffected side. So you'll have a tracheal deviation to the unaffected side. Okay? So if listening and, well, really, if you walk in the room and you see the mediastinal shift, and it may be subtle, you may not even pick up on it, but when you walk in the room, patient's struggling to breathe, you're looking, okay, you see this mediastinal shift, and it may be that you're still not sure. But then when you listen, what are you going to hear? Yeah. Nothing, at least diminished, depending on how bad the pneumothorax is, but at least diminished, possibly or more likely nothing. Absent bowel breath sounds. Okay. Yeah, not bowel sounds, but breath sounds. So the absence of those breath sounds. All right. So we covered a lot of them. Pain on the affected side that's worse at the end of inhalation than at the end of exhalation. Second, rapid heart rate. Okay. Again, now why do you think we're going to have a rapid heart rate? Okay. The heart's trying to compensate because we have a half of our breathing cycle is or not cycle, but our breathing structures are diminished here. So we've got one lung that's trying to now do the work for two. Okay? So the heart's having to work harder to bring blood in faster so they can circulate. Don't forget about the little the hemodynamic seesaw we've got here. We've got to meet the demand for the body. If we reduce one of the structures that does that, the other side has to pick up the slack. Okay, we still have the same demand, probably even more so now, because we've got an issue going on. The body's kind of freaking out. So our oxygen demand has gone up, or even greater. Absolutely. Yeah, we're going into fight or flight for sure. The body's panicked because it can't breathe. Okay, or the tissues are being deprived, or it recognizes an issue. The respirations, they're going to be rapid. They got to bring in more air faster. Okay, shallow respirations. Why do you think it's going to be shallow respirations? Okay, yeah, we've got one lung that's collapsed, and what's going on here? Okay, we got pressure. It hurts. Okay, if it hurts to breathe in, are you going to try to breathe in as much as you possibly can? Usually, it's so painful. Breathing in shallow because it doesn't hurt quite as bad, but it's a little faster. Okay, or a lot faster. So rapid, shallow respirations. Feeling of air hunger. Patient just feels like they can't get enough air in. Okay. Prominence of the affected side that does not move in and out with respiratory effort. Okay, what does this mean? Prominence of the affected side. What's prominence? Okay, it's not moving, rising and falling. So the other side, we're watching those respirations and we see one side moving, one side's not. Okay, what's prominence? It's noticeable. It's not necessarily just completely sucked in. Okay, it's out. It's just not moving. Okay, prominence of the affected side does not move in and out with the respiratory effort. And then here's our mediastinal shift. We see it with the trachea. Okay, tracheal deviation. Trachea slanted more to the unaffected side than to the center of the neck. Okay. And here's a big one. New onset nagging cough. Okay, you'll see this with a lot of different issues that we've talked about, and we've talked about or we were about to talk about. New onset nagging cough. Okay. What's another condition we talked about previously that had the new onset nagging cough? Possibly, but that's not the big one. There's one that we talked about. Deals with oxygen. You got a patient on oxygen, 24 to 48 hours. If you're getting too much oxygen, what's that called? Oxygen toxicity. New onset nagging cough. Oxygen toxicity. New onset nagging, just don't stop. They're coughing, and they just can't. A lot of times they can't even get a breath. So we've got the pneumothorax going on. So we're trying to get the rapid respirations going to compensate. Then they can't even get rid of the cough to breathe. Just nagging. It's just, I don't know. It's driving them crazy. Yeah, new onset. It's not something that they came in with. Okay, they haven't been having this. They haven't had this cough since the admission. This is a new thing. a new development. With oxygen toxicity, it's going to be it's just a gas exchange issue. I mean, you're not going to have oxygen toxicity with this. No. Oxygen toxicity is because we gave them too much oxygen. That's just a common, new onset nagging cough is a common symptom of the oxygen toxicity as well. They definitely won't have oxygen toxicity at this point. It's two completely separate things. They're trying to breathe. It's a gas exchange issue. They just start coughing, trying to bring in more air, I guess. I don't know. I don't know exactly why. It's usually just that's a common sign of a gas exchange problem. That new onset nagging cough, and usually it's a dry cough. They're not coughing anything up. They're just hacking. Dry nagging cough. Okay, and then the cyanosis. I mean, well, not just cyanosis, but any sign of lack of oxygenation. Okay, as a result of the pneumothorax, you're going to have tissue deprivation of oxygen. Okay, you're going to have the hypoxia. All right, so that's a pneumothorax. Okay. Next, we have a hemothorax. Okay, it's similar, but not completely. With pneumothorax, we have air. We have some kind of hole or issue that causes air to move in to the chest wall, increasing the pressure. With a hemothorax, now we have blood that enters the pleural space. Okay, blood enters the pleural space. Pressure builds outside of the lungs as a result of increased blood density. Okay, increases the pressure outside of the lung and puts pressure on the lung. Okay, this can also lead to the collapse. It's just a different, it's a different issue or source of the pressure. Manifestations will resemble pneumothorax with the addition of signs of blood loss. So what are signs of blood loss? Okay, patient pale, absolutely. Okay, so shock. Okay, so what are the signs? Yeah, so they'll have tachycardia, but what will accompany the tachycardia? Yeah, increased heart rate, hypotension. So tachycardia and hypotension. Okay, those are huge ones there. Heart beats faster, but it's losing pressure. All right. Now, the hemothorax is often more subtle. They're not going to be as pronounced. You're not going to have that rapid change in pressure. With this, we've got a break here in the integrity of the chest wall. Air rushes in. The collapse is going to be pretty. It's going to be rapid. I mean, it's not going to be something that gradually occurs. Hemothorax, depending on how much blood we have in the cavity, it's usually going to be kind of a gradual rise in that pressure. Removal of blood from the pleural space with chest tubes is going to be the focus of treatment, in addition to replacement of fluid and blood volume. Okay. Now, we've talked a little bit about. We'll leave that for a minute when we talk about chest tubes. All right, chest tube placement. This is the location of where we would place a chest tube. Okay. If we're trying to drain off air, why do you think we would do an air chest tube? Just to drain off air higher up. There you go. That's it. It's gravity. Fluid is going to fall. So if we're trying to drain off fluid or blood, our chest tube is going to be here. Now, it's maybe that the patient requires both. Depends on the issue. But if it's air we're trying to drain off, well, we're going to do it higher because air does what? It rises. Okay. But the blood and all the other fluid is going to fall. These are the locations of where you would have the actual catheter enter. depending on the location. If it's a blood drainage tube, it's going to be a little lower. The air drainage tube is going to be higher. Now, the chest tube itself is going to have 3 chambers. Okay, and I'll just let you look here. This is a typical chest tube system. Now, all of these chest tube systems, they have variations to them. You know, you may have the drainage on the left or the drainage on the right, or different ways that they hook up or locations, but they're going to have 3 basic chambers. Okay, first you're going to have the drainage chamber, and I know this has got 3 spots here, but this is all one chamber. Okay, this is the drainage collection chamber. As drainage comes in from the patient, okay, now remember this is the tube, okay, that you would see, okay, as it comes in here. Then this is the collection chamber side of things. This is where it would come in from the patient. Drainage collection, drainage is going to drop here. Same thing, same principles. Gravity causes the drainage to come in and fall into the chamber. Okay, as it collects, it rises and it moves into the second chamber, or second section of chamber 1. Okay, now again, air does what? It rises and stays up. So now we have a device, the water seal chamber. This acts as an air suction via a one-way valve. And our one-way valve is water. Okay? We pull the water, or pull the air through the water, it bubbles, and it ends up on this side. Now, is air going to go backwards, back through the water, if it's not sucked through it? No. So that's how it works, as that one-way valve. So we've got the air that comes through as a result of the suction. Okay? So we're sucking out the air and the drainage. The air stays up, moves through the water seal chamber. The way you know that air is moving through the chamber and being sucked off there is going to be the water seal. Okay? If it's bubbling, that's how you know that air is moving through that chamber. All right? The third chamber is going to be your suction control. This is how we determine how much suction is being applied to that device. Okay. We're going to regulate the amount of water here, and that helps us to regulate how much suction is being placed on that chest tube. We've got the now there's different that's going to be regulated by the physician. The physician is going to come in and say, I want this much suction, and then we will adjust accordingly. All right. Now, where do you think? What's the positioning we need to, or where do we need to have a chest tube? The collection system. You may have an idea. Okay, it's got to be usually on the ground. It's got to be below the level of the chest. Okay, we want these principles of the gravity, okay, to be able to function. So we want the chest tube system needs to always be preferably on the ground. Okay, secured on the ground. We want to make sure we tape it, or at least secure it to where it's not going to get knocked over. We don't want a patient to accidentally get up and walk around and trip and knock it over. Because what happens is all these chambers start to get mixed together. And if that happens, you just have to change out the chamber system, the chest tube system. All right. Some more of the nursing care aspects. If you're caring for a patient with a chest tube, you fill the water seal with sterile water at a specified level. Again, that's going to be given to you as an order by the physician. You don't adjust the water seal chamber unless you have a physician's order. Okay, you're not going to adjust that water level because that's controlling how much suction we want to have on that chest tube. You fill the suction control chamber with the sterile water to the 20 centimeter level, and then we're going to adjust it based off of that, or based off of the physician's order. But you're going to have the 20 centimeters of water in the chest tube, and then we adjust the pressure accordingly. You attach the chest tubes to the collection chamber with tape. You want to make sure that you have a good seal. If you don't have a good seal, what do you think is going to happen? It's not going to do its job. We want it to be a nice closed system, but also you've got a source of infection as well. You want it to be a nice and closed system, fully occlusive, and that way it can pull off the right amount of pressure as ordered. The suction, you always want to follow the physician's orders regarding the type and amount of suction pressure. And here's a big one: keep an occlusive dressing at the insertion site. Okay, so against the body, well, the insertion site, you're going to have always make sure you've got a good occlusive dressing. If you don't have a good occlusive dressing, again, you're going to change the way that suction is being applied. Okay, you always want to make sure you've got a good Vaseline gauze or occlusive dressing at the site. Also, you want to have sterile gauze at the bedside to cover the site immediately if the chest tube becomes dislodged. All right, and then you also want to make sure if you've got a chest tube patient, you keep clamps at the bedside if the tubing becomes unhooked from the system. Okay, what happens if it becomes unhooked from the system? What do we have? Yeah, we got a mess. Absolutely. Risk for infection, but also what could change? The pressure. Now, you have a change in interpleural pressure, you could have that, collapse. I mean, the lung itself could collapse again. You want to make sure that pressure is constant. Okay. In most cases, we're not going to use the clamps. If you walk into the room and the system has become disconnected, you're going to try to get that thing connected as quick as you possibly can. Okay, you want the chest tube to do the chest wall expansion. You don't want to have to clamp it to keep that pressure intact. But you do need to have them at the bedside. All right. Other things, you want to mark the chest tube drainage on the collection chamber with the date and time. Drainage should be recorded every hour for 24 hours post-op or post-insertion, and every 8 hours until removal. So if you look back here at our system, you're going to mark, and if you can see here, they've got numbers, they've got volume units that you can see here on the side as it goes up. So you're going to mark the drainage level. For 24 hours, you're going to mark it every hour. And this is usually because during that first 24 hours, they're probably going to put out a lot of drainage. That's going to be the time when they put out the most. So we're going to monitor that closely. But at the end of each shift, you absolutely have to mark the chest tube. You have to mark the date, the time, and where that level was with your initial. Okay. The physicians usually, they're going to use this to determine when they want to remove the chest tube. So if it's not done, you're going to see some ticked off doctors, but also they're not going to be able to determine as accurately of when they need to remove that chest tube. All right, you always want to check for kinks or loops in the chest tube. Okay, make sure we hadn't got a knot or something blocking the chest tube. Again, it's going to change that pressure. It's going to change the ability of the chest tube to pull off the drainage and also there. Also, you want to observe for appropriate titling. So you might know what titling is. What was that? No, it's when it's going to move inside the chest tube. Okay, you're going to have fluid that kind of moves, similar like an NG tube. Okay, the NG tube, you've got movement of the fluid and it cycles. Okay, it just kind of sits there and looks like it's coming out, but it's not really. It's that movement. Okay, that is an appropriate sign. That tells you that it's working. The suction is working. Okay. You do not want to. Well, you want to observe for air leak. Make sure that there's no leak in the system, but you don't want to strip or milk the chest tube. You might know what milking or stripping the chest tube is. You're pulling basically clots or blockages out. We don't necessarily want to do that. Unless the doctor specifically gives you an order to do that, you don't want to do it. Okay. Aggressive chest tube manipulation. could generate extreme negative pressures in the tube, and it does little to maintain the chest tube patency. Okay. All right. Don't forget about the overall pulmonary movement. Okay. Incentive spirometers, cough and deep breathe is very, very important. Okay. Do you think these patients are really going to want to breathe in deeply? Same reason as we talked about before. They have pain on inspiration, so they're more likely to try to, have these nice shallow, or not nice shallow, but just these shallow, slow respirations. You want to encourage deep breathing, encourage the pulmonary toilet. And then finally, you want to observe and report any changes in status. Okay, what changes are you going to look for? Respiratory changes. All right, so what type of respiratory changes? Okay, so yeah, difficulty breathing, absolutely. What else? Okay, changes in circulation. So what are going to be the signs of the breathing, difficulty breathing and circulation changes? Okay, changes in cat refill. O2 sats, a big one. In most cases, they're going to have, if a patient's on a chest tube, they're going to have continuous O2 sats. Okay, you need to monitor them at least every hour. Take a look at them, make sure that you're not having significant changes there. What else? We hadn't even mentioned a big one. What are you going to want to do? Listen. What are we listening for? Breath sounds. Yeah, we got to listen to breath sounds. If I walk in the room and the patient's struggling to breathe, and I listen to them, and we've had diminished or absent breath sounds, what may have happened? Yeah, I mean, we may have an issue with the actual location of the chest tube itself. We may have pneumothorax has reoccurred. Some issue, that's caused this change in stats. But that's a big one. You got to really make sure that you're looking not only for O2 sats, but also the breath sounds. All right. Now, in the event of the chest tube disconnection and contamination, you may submerge the tube in 1 to 2 inches of water, sterile water. It's a 250 ml bottle is what they usually keep at the bedside. 250 ml bottle. You can take the chest tube and insert it 1 to 2 inches into that bottle. And that's basically doing the same thing as this chest tube. Okay? Used to, that's what they used. They used glass bottles. You'd have a glass bottle there, and they would actually insert them into a glass bottle, and it keeps that pressure constant, where it allows you to reinflate the lungs, basically. Same thing as the chest tube there. All right. Next, we've got acute respiratory failure. Acute respiratory failure is a breakdown in the gas exchange process that results in hypoxemia and an inadequate transport of oxygen to the cells. Okay, it's defined by blood gas abnormalities with an O2 of less than 60, PaO2, the SaO2 of less than 90%, so arterial oxygen saturation of less than 90%, and the PaCO2 of greater than 50 that occurs with a pH of less than 7.3. So what do we have here? If we've got a CO2 of greater than 50 and a pH of less than 7.3. Respiratory acidosis. Correct. The different types of acute respiratory failure. First, we've got ventilatory failure. This is a problem of ventilation. Okay, and ventilation is oxygen intake. Okay, so problem of ventilation, perfusion, which is the blood delivery component, and then the chest pressure does not change enough to allow air movement into and out of the lungs. Causes of ventilatory failure, we've got COPD, asthma, central nervous system changes. Okay, what type of central nervous system changes could you think of? How is it involved? Okay, CNS depression, yeah. What would cause the CNS depression? Drugs, definitely. Morphine, trauma, absolutely. Spinal cord injury is another one, and that's kind of connected to the CNS depression. What types of drugs? Okay, our narcotics, morphine, Dilaudid, Demerol, all that good stuff, depresses that nervous system function. Okay, we've also got obstructive sleep apnea, pulmonary edema, and then neuromuscular disorders. All right, these are all ventilatory problems. These are problems with the ventilation aspect. Okay, the oxygenation failure is going to be a problem with perfusion. Ventilation is normal, but we have a problem with perfusion. So oxygenation failure is a problem with perfusion. We're bringing air in normally, we just can't get it to where? To the tissues. Okay, so air movement in and out of the lungs is normal, but exchange of gases at the alveolar level is going to be impaired. This occurs with inspired air with decreased oxygen concentration. When might we be breathing in oxygen or air that has diminished oxygen concentration? Okay, there's a lot of people in the room. Yeah, absolutely. I mean, it's possible. If you got an enclosed space, a lot of people, absolutely. What else? High altitudes. What other occurrences? Yeah. Yeah, you're suffocating yourself, basically. Mm-hmm. Sure. What else? What if we inappropriately administer oxygen? Okay. What's an occurrence that we talked about with that? What if I put a mask on and I put it on 2 liters? What am I doing? Yeah. In this case, not only am I not giving an adequate oxygen concentration, I'm not giving you any oxygen, really. Because we're just basically suffocating you by putting a mask over your face. Because what does a mask have to be at before it's giving you oxygen? 6 liters. Yeah, you got to have the 6 liters of oxygen before you're giving anything. Okay? All right. Also, we've got the CHF with pulmonary edema. It's going to be a perfusion problem. We can't move the oxygen into the blood. Decreased hemoglobin levels. Why would decreased hemoglobin levels be an issue of perfusion? That's the carrier. If we have diminished hemoglobin levels, we have diminished carriers of oxygen. So those components that take the oxygen and move it to the tissues are diminished there. All right. Hypovolemic shock. Same thing. Hypovolemia, what is that? Low blood levels. So if we have low blood levels, hemoglobin levels are going to drop too, right? So we've got a diminished carrier, diminished ability to transport the oxygen. Hypoventilation, it's probably more of a ventilatory issue, but if you're bringing in less oxygen, you're having a problem with the, let's just scratch the hypoventilation. That's not even really going to be a perfusion issue. The hypoventilation is going to be the cause of the ventilatory failure. And then pulmonary edema, pulmonary embolism. Why would pulmonary embolism be an issue? What is a pulmonary embolism? Clot that moves to the lungs, the lung circulation, so we have diminished circulation. Okay? Now, diminished circulation through the alveoli where that gas exchange can occur. And then finally, pneumonia. All right? Hypoxemia is going to be the result of both ventilatory and oxygenation failure. Okay? So just because it's a ventilatory problem does not mean hypoxemia is not going to occur. It's going to occur with both. It's just the source. Where is the problem with that respiratory function occurring? Let's take here. All right, so continuing with acute respiratory failure, these are the treatment options. Okay? Pretty simple. Oxygen therapy to maintain PaO2 levels above 60. Okay? We want to maintain the oxygen levels in the blood at least greater than 60. Okay? Yeah, I mean, that's pretty self-explanatory. If we have a problem with respiration, or not, if we have an oxygenation issue, we're going to try to improve the oxygenation. The remaining treatment options are going to center on determination and treatment of the underlying cause of the respiratory failure. There's lots of different conditions that could cause respiratory failure. Well, can any of you think of any? What could cause respiratory failure? Okay, heart failure, absolutely. Because it's any issue related to ventilatory or oxygenation problems. So, well, I guess we've already got them listed here. I mean, you know, COPD, asthma, heart failure, CNS issues, okay? It could be a lack of recognition by the brain that we have increased CO2 levels. Because what does the brain do? If the brain appropriately recognizes an increase in CO2, what does it do? It increases what? Well, now the CNS is not going to increase bicarb. It's going to try to decrease CO2 by increasing respirations. Okay, so the CNS recognizes these increased CO2 levels, and it says, we got a problem. Let's increase our respiratory rate to blow off more CO2. Okay? You have an alteration in the CNS system, you know, the alteration in the brain, you could have reduced sensitivity to CO2. Also comes along with COPD. We'll talk about that here in a little bit too. Again, the pulmonary edema, neuromuscular disorders. All of these are issues that could lead to respiratory failure. Okay. All right, so now we're going to talk about basically the respiratory failure has progressed into basically an issue known as acute respiratory distress syndrome, also known as ARDS, as characterized by sudden progressive pulmonary edema, causing increased bilateral infiltrates, and also hypoxemia that is not improved with oxygen therapy. Okay, so we have diminished blood oxygen levels. We give oxygen, and it's not improving things. Okay. We've also got decreased lung compliance. And what did we say decreased lung compliance is? It's reduced ability of the lungs to do what? Expand and contract. Okay? So if you have decreased lung compliance, the lungs are not able to expand and fill with air and contract and exhale. Okay? All right. Sorry. Did you need that? Good now. All right. All right. So some of the pathophysiology. ARDS is a result of inflammatory triggers that damages and collapses the alveolar interstitial spaces. So if we have the alveoli collapse, what happens? No gas exchange is going to occur there. Okay. This can be the result of direct injury to the lung or lungs through trauma or smoke inhalation. And this is acute. What type of smoke are we talking about here? We're talking about like smoking. Smoking is more of a chronic. Fire is going to be more of an acute issue, right? Inhalation of smoke, large amounts of smoke usually, okay? And this is going to be an acute exacerbation of these symptoms. It can also be a result of aspiration or infection. Also DIC, or disseminated intravascular coagulation. Okay. Does anybody know what DIC is? Okay, y'all learned about that? Good. So you know it's basically inappropriate activation of that clotting cascade. Okay. So we won't go too far into that. We've already learned about it. All right. Indirect causes. Indirect causes could be the result of shock or major surgery. All these things could lead to the inflammatory triggers and also the acute respiratory distress syndrome. All right, so in the manifestations you'll see severe dyspnea that occurs 12 to 48 hours after the insult, arterial hypoxemia regardless of oxygen amount. Okay, we keep giving them oxygen, bumping it up, keep bumping it up, keep bumping it up, and they keep getting progressively worse. The lungs are stiff. That's the whole decreased lung compliance issue. And diagnostic findings, we're going to have alterations in ABG levels. Okay. Usually the PaO2 is not going to improve regardless of how much oxygen we give. We'll evaluate sputum cultures, evaluate for the, or we'll look at sputum cultures, evaluate for the presence of infection. Again, with this, we're trying to treat the respiratory. We're trying to bring up the PaO2. It's not working. So now we've got to find what is the underlying problem. What's the underlying issue that's causing this, the lack of oxygenation? So that's where the sputum cultures come in. Chest X-ray, we're going to have a white, hazy appearance in the lung fields. Air is not coming in and moving out. All right, so those are manifestations. Now here's what we're going to do. We're going to try to identify and treat the underlying cause. The patients, almost always, if they are in significant ARDS, they're going to have to be intubated with mechanical ventilation. The goal is going to be 60 or higher. We try to get that PaO2 up to 60 or higher, and or O2 sats of 90%. Okay. They're going to be on hemodynamic monitoring. Usually this is going to entail set up an ART line. You can, in real time, monitor these ABG levels. Okay, we can quickly obtain arterial blood samples. We can, frequently assess these ABG levels. All right, some of the meds, we've got human recombinant interleukin-1 receptor antagonist, neutrophil inhibitors, surfactant, pulmonary vasodilators, and corticosteroids. One of the big things here is going to be nutritional support. Okay, we want to make sure that the patient gets in at least 35 to 45 calories a day, or per kilogram per day. High protein. Okay, we want to make sure that we're getting, I guess, the biggest bang for our buck here. We don't want to have these patients. Well, commonly they're going to be intubated. Okay, so we don't want to, have their nutrition, the actual body wasting occur. Commonly, most commonly, they're going to be intubated, so we're going to give maybe hyperalin lipids. Okay, some kind of TPN. Patient positioning is very, very important. Okay, frequent turning. Turn, cough, and deep breathe. The cough and deep breathe part may be an issue. We can kind of control that a little bit with the mechanical ventilation, but absolutely, from a nursing care standpoint, you're turning frequently. Suctioning is going to be an issue. Make sure you're there and able to suction as much as you possibly can, or as much as the patient will allow. All right, you also want to monitor and implement the medical plan of care, provide psychological support, and then ventilator considerations. Don't turn off the alarms. It should be pretty self-explanatory. Monitor for hypotension. Monitor the patient fighting the ventilator. Okay. Patient may have to be sedated. They may have to provide sedation to prevent them from fighting the actual ventilator. Suction frequently. Administer a bite block as needed, and then sedation, and then the neuromuscular blockade as well. That stuff is not necessarily going to be neuromuscular blockade is not going to be you, but you would want to monitor for that. Okay. All right. So those are our acute issues. Now we're going to talk a little bit about our chronic issues. First, we've got lung cancer. Okay. Lung cancer is a neoplasm that occurs in the lungs, and it's the leading cause of cancer deaths worldwide. There's a poor long-term survival rate due to late-stage diagnosis. As with any cancer, the earlier they can diagnose, the easier it is to treat. To give you an idea, the 5-year survival rate is approximately 14% from the time of diagnosis. And cigarette exposure is going to be the cause of 80 to 90% of all lung cancers. All right, the risk factors include tobacco smoke, so direct inhalation of cigarette smoke, also secondary smoking, or secondhand smoke. Environmental and occupational exposures also play a big role, and then genetics as well. All right, you need to know these. The pulmonary manifestations, specifically. Pulmonary manifestations of lung cancer include a persistent changing cough, a dry hacking cough that can turn to productive as the disease progresses. All right, dyspnea, cyanosis, and clubbing of the fingers. What are these signs of? Oxygen deprivation of the tissues. Okay, and are these acute signs or chronic signs? Chronic. So pretty much most, if not all, of these chronic conditions we talk about, these are chronic signs of a lack of oxygenation. Okay? They don't occur overnight. Next we've got hoarseness. Missing an E, but that's hoarseness. All right. Hemoptysis. Can be rust or purulent sputum. Not always hemoptysis, but it can be. Usually it progresses. It may start out clear and then move to the blood, blood tinged. Chest pain's a big one. Diminished breath sounds with an occasional wheeze, and then reoccurring episodes of pleural effusion, pneumonia, or bronchitis. And this is usually why it's a late diagnosing type issue. These patients come in with pleural effusion, pneumonia, bronchitis. They just come in constantly. It's they just can't get over these conditions, and then they finally find, okay, yeah, there's the reason. We've got the lung cancer that's there. All right. Non-pulmonary manifestations include weight loss, fever, fatigue, muffled heart sounds, and also dysrhythmias, reoccurring fractures, nausea and vomiting, and then changes to mental status, or not mental status, but mental changes or psychological changes. What type of psychological changes would you want to look for? Confusion, yeah. I mean, it could be, and I see where you're going with it. You could have changes in mental status from what type of issue? Cerebral hypoxia, okay. But from a psychological standpoint, what other kind of issues may you have? What comes with any cancer? Yeah, you could have depression, anxiety. They're worried. I mean, they're worried about their life, their life expectancy. They've been diagnosed with cancer. You as a nurse, you've got to support that, and you've got to give them a chance to at least voice those concerns. You can alleviate some fears. Some fears are valid. There's issues that, you just got to be honest with them. But you need to consider that as well. Diagnostic evaluations, and I've got it down here. Apparently I didn't get it on the slide, but some of the diagnostic testing things that you would look for with cancer. Cytologic testing is pretty important of the early morning sputum. So commonly they'll have, they'll order overnight, maybe first sputum of the morning, or try to get them to cough and give you a sample first thing in the morning. This helps to identify tumor cells in some cases. So this can be used to actually diagnose or confirm the presence of a tumor. Fluids can be obtained by thoracentesis. So they can, do a thoracentesis and evaluate that fluid using the cytological examination. And then finally, we can look on chest X-rays, CT scans. You can actually visualize the tumor. Okay. That's probably going to be your most common diagnostic tool for determining the presence of lung cancer. All right, some of the treatments. Well, the treatment's going to depend on the size, location, type of cancer, as well as the overall health of the patient. There are different options that, depending on the age of a patient or the overall health and well-being, the patient may not be up to receiving those treatments. But that's going to be considered when we're looking at the non-surgical interventions and surgical. Again, we're not going to be specifically involved in that decision-making process. We may help, provide the patient an ear to, kind of voice their concerns or things like that. But we're not going to specifically decide that. But our non-surgical interventions, including chemo, radiation, and palliative care, you need to be aware of those, the nursing care involved in that. Okay. Some of the different surgical procedures they will use include, well, depending on the site and location, but a thoracotomy is just going to be the incision into the pleural space. Okay. We talked about the incision here. If they perform an incision into that pleural space, that's a thoracotomy. Okay. A lobectomy. I'll let you guess what a lobectomy is. They remove a lobe. Okay. Depending on the size, type, location of the tumor, they may have to remove an entire lobe. All right, pneumonectomy. What do you think a pneumonectomy is going to be? An entire lung. Okay, they may take off an entire lung. And then segmentectomy, well, they don't take an entire lobe, but maybe they take a section of the lobe. They're able to kind of narrow it down to a certain portion of that lobe or that lung. So removal of the tissue of an involved lung segment or segments of a lobe. And then the wedge resection is going to be removal of the peripheral portion of a small localized area of the disease. So our non-surgical management, we talked about this, the chemo, targeted therapy, they isolate and they provide the treatment there at a localized level. Radiation therapy, and also the photodynamic therapy. Here's the key. This is what you kind of need to know. Well, specifically with chemo, okay? Chemotherapy patient, one of the manifestations you really want to watch for is mucositis. Okay, the ulcerations of the mucous membranes. Anytime you see that, it's going to be, you need to contact the physician immediately. It's not something that you're going to give. Well, in most cases, the physician does not want the patient to continue to receive that type of chemotherapy with the mucositis, occurring. So you would want to make sure you call the physician before you give another dose. But that's why frequent mouth care is so important. So you're going to provide that oral care. You're going to provide the mouth care and make sure that, well, you want to kind of prevent the mucositis from occurring, but you also want to have the ability to recognize when it does occur. Okay. Some of the other nursing management, well, you want to relieve the symptoms for the most part, primarily of the dyspnea, fatigue, nausea, and vomiting. Okay, you've got to be there to kind of make adjustments to the care. You're still providing the care that is ordered by the physician, but maybe you're not going to go in similar to some of these other chronic lung disease type patients. Are you going to want to go in at 8 o'clock and knock out every nursing order that you have for the day? If they're struggling to breathe, if they're having dyspnea, if they're having issues with the dyspnea on exertion. No, you're going to want to kind of space things out as much as you possibly can. That's a nursing, a nursing application of these things. You got to recognize that and help to manage that care throughout the day. You also want to relieve any breathing problems as much as you possibly can. Okay? If the physician's ordered oxygen, the patient's having trouble breathing, you can apply the oxygen. Okay? Turn, cough, deep breathe as much as possible. Provide that psychological support. And I always kind of preface that you always want to make sure that you are there to listen to the patient as much as they need, and then as you can, you may refer out to support groups. You may refer out to a chaplain. You may refer out to all the different specialties and services that are available. But listen to the patient's concerns first, so that you have that ability to refer out to the different disciplines. All right. Next, we've got asthma. Okay, I'm sure you've all been impacted or know somebody that has asthma. Asthma results in 5,000 ER visits each day in the U.S. alone, and 217,000 ER visits each year. Also, 1,000 hospitalizations each day, and 500,000 hospitalizations each year. And there are 10.5 million physician office visits directly related to asthma each year. And then asthma increases the odds of healthcare use in obese people by 33%. Okay. And this is similar, but 20 million Americans are affected, or 8.4% of the population. An estimated 300 million people are affected worldwide. It is more common in adult women than men, and slightly more prevalent among African Americans than Caucasians. The numbers of people with asthma does continue to grow. I mean, it's significant. So what is asthma? Well, and this is important. This first sentence that we're talking about here. And this is going to be a very important distinction, and we'll talk about a little later. But asthma is an intermittent and reversible airflow obstruction affecting the airways only, not the alveoli. Okay? So this is an airway problem that is intermittent and reversible. Now, does that mean that asthma, you can give them something and asthma is not going to occur anymore? No. That means these acute episodes of airway obstruction are reversible, okay, in most cases. We'll talk about another condition later that's a little bit tougher to alleviate, but it's intermittent and reversible airflow obstruction. The result, it could be caused by inflammation or airway hyperresponsiveness that leads to bronchoconstriction. Okay, so swelling, fluid buildup as a result of inflammation, or the actual bronchoconstriction. What's bronchoconstriction? Okay, constriction, airways constrict, so they get smaller. Okay, right, and here's a pretty good graphic of that. This is a look at a normal airway. Okay, normal bronchial tube. This is all open. Okay, this is the smooth muscle, and this is the opening of the airway. Okay, this is a patient in an asthma attack. Okay, this is the same bronchial tube under an asthma attack. This is the airway. That small dot right there in the middle, that's the airway. This is smooth muscle inflammation and edema. Okay, not inflammation, but it's inflammation of the airway there. So now you've got a much smaller diameter airway. So that's where the problem occurs. Okay. Now, there's different problems or triggers that can cause the asthma attack. And that's kind of how we alter how we treat the asthmatic patient. But it can be caused by specific allergens, general irritants, microorganisms, and even aspirin. Okay. Aspirin can also cause asthma in some patients. The hyperresponsiveness can also be caused by exercise, upper respiratory infections, and then also we really don't know. unknown etiology, unknown reasons. Based off of this, okay, you get a patient that maybe they're in a clinic and they have not, maybe they're not actively having an asthma attack, or maybe they are. Really, both would apply. What needs to be the nurse's first interaction? If the patient's stable, now we're not talking about an asthmatic patient that's unconscious or having trouble, I mean, just an acute exacerbation. Maybe they're having asthma issues, maybe more frequent attacks. What needs to be the nurse's first interaction with that patient? What does the nurse need to do when they are first chronic? Okay, and what was that? Okay, so find out what causes maybe in them, what are their specific triggers? Absolutely. What else? Okay. So what's their normal treatment options, right? What do they normally have available if they do go into an asthma attack? Good. And what are we doing with both of these? Okay. Well, what is that? You walk into the room and you start talking to the patient. What are you doing? Assessing, but also you're obtaining what? A history. Okay. You want to get a good history. You want to get a good foundation. This is what's going on with my patient. This is what typically causes the triggers. Okay. Maybe find out what else is going on. Okay. Especially, look right here. If we're looking at aspirin, general irritants, microorganisms, specific allergens. What are all these things that we're looking for? What are we trying to get to the bottom of? Okay, so what's causing, what are they exposed to now that maybe they haven't been exposed to previously? Is there a new thing that's been introduced? Aspirin. Maybe they're taking aspirin, maybe they've got arthritis. Maybe they've had a flare-up of arthritis, and now they're taking aspirin, which I don't necessarily typically say, let's take a bunch of aspirin, but find out if there's something new that they've started taking for maybe an unrelated condition. What other issues do they have going on aside from the asthma that could, as a secondary result, cause the asthmatic attacks? Okay. It can just be a trigger in some people. It's kind of like, not necessarily an allergy, and I don't even know what part of the aspirin causes it, but in some patients that can be a trigger for the asthmatic attack. The key you need to know, you just need to know, hey, look, we're looking for what's the underlying problem that's going on with this patient. Never underestimate the importance of that history. Okay, find out what's going on. Well, and that's what we talked about there, the history. Next, you're going into your assessment. Okay, your physical assessment and looking for the clinical manifestations. Asthma is going to produce audible wheezes, increased respiratory rate. If the patient's having trouble breathing, we've talked about the signs. What are the signs of trouble breathing? Well, increased respirations. What else? Okay, accessory muscle use. Okay, tripod position. They naturally go into that tripod position. What else? What else might you see? Okay. Pursed lip breathing. Absolutely. Accessory muscles. What else with the physical appearance? Okay. Could be barrel chested. It's barrel chested because it's an acute or a chronic type issue. Chronic. But no, asthma is a chronic issue. If a patient has chronic asthmatic attacks, they may develop the barrel chest. That's a sign of chronic hypoxemia, or hypoxia, really. Okay. The heart rate is going to go up. Remember the anxiety. They're going to be panicked. It's pretty common. That's those are the things. All of the typical signs of respiratory issues. If they're having a respiratory or asthmatic attack, those are going to be the signs. You add in the audible wheeze. Okay. What does a wheeze indicate? Obstruction, some type of occlusion in that airway that prevents air from moving in and out. Okay, there's your wheeze. The barrel chest from the air trapping, long breathing cycles, cyanosis. and hypoxemia. Typical signs of a respiratory issue. Okay. All right. So lab assessments. We're going to look at ABGs. Okay. And on the ABGs, you think what are the ABGs typically going to look like? Okay. Well, it's going to be a respiratory problem, right? So typically, your pH is going to move with the CO2, right? In this case, probably most commonly, it's going to be a CO2 issue. Not a CO2, but a acidosis issue because of increased CO2 levels. So typically, the asthmatic patient that's been frequently having respiratory issues, you're going to see the pH in acidosis, respiratory acidosis. The arterial O2 may decrease in an acute asthma attack, and arterial CO2 may actually decrease early in the attack and increase later. Okay, so if our CO2 decreases early, we may start out alkalinic, but then later move to the acidotic. Okay, and it may not even be altered. It may not be acidosis or alkalosis, but you may see that movement of pH from more of the alkalinic side to the acidic side. Allergic asthma, these patients are going to have elevated eosinophil counts. Also immunoglobulin E levels. Sputum may also contain the eosinophils, mucus plugs, also with the shed epithelial cells. These are things we're going to look at from a diagnostic perspective. Okay. Pulmonary function test. These patients are going to get real good at pulmonary function tests. Most accurately, these are going to be used with spirometry. We're going to look at the forced vital capacity, the forced expiratory volume in the first second, and the peak expiratory flow rate. Okay. And what are these signs of? What are we measuring here? Yeah. How much volume of air are the lungs bringing in? Okay. And how well are they able to exhale that air? Okay. These are volumes that we really, really look at. Drug therapies are going to be based on a step category for severity and treatment, basically tailored to the patient. Okay, the physician, practitioner, whoever is going to set up these rescue treatments, or not even rescue treatments, but the baseline treatments for the asthmatic patient based on their condition and their well-being. Preventative therapy is going to be used. These are the controller drugs. These are the medications that the patient must be educated on to take every single day, regardless of how well they feel like they're breathing that day. This is not something we alter based on, respiratory function. Okay, because if the preventative drugs are working, well, they should be breathing better. They shouldn't have the issues. So these are our maintenance drugs. Rescue drugs, on the other hand, these are the things we give once the attack has started. Okay, when the breakdown has occurred, or maybe the maintenance drugs haven't done what they need to be doing, and they're exposed to a new trigger, they're exposed to something else, then you would have the albuterols and the MDIs that we would give as rescue drugs. Okay. All right. So this is a look at one of the typical plans that the physician will set up. The peak flow levels are going to be based on the patient's normal peak flows. All right. If the patient's at 80 to 100% of their normal peak flow rate, then they're in the green zone. They just need to continue these maintenance drugs that they're taking every day. All right. A reading in this zone means that the asthma is under reasonably well controlled. It would be advisable to continue prescribed program of management. Everything's good. This is where we want them to stay as much as possible. Now, when they start moving into the yellow zone, this is an indication that the patient's moved to 50 to 80% of their normal peak flow rate. This means they're starting to have some issues. At this time, there's going to be a specified, tailored for this patient treatment. Okay? When you go into the yellow zone, this is what you need to do. Ordered by the physician, okay, or a practitioner. Usually an MDI, albuterol inhaler, something like that. You take your inhaler, wait however long, and then recheck it. Recheck your peak flow rate, and hopefully they've moved from the yellow zone back into the green zone. Okay? If they haven't, there's another set of protocols. This is what you need to do next. Now, if they move into the red zone, this is kind of the go get some medical treatment kind of zone. Less than 50% of their normal peak flow rate signals a medical alert. Immediate decisions and actions need to be taken. In this zone, severe airway narrowing has occurred or may be occurring, and they need to continue the rescue drug treatment and go see or contact the healthcare provider, depending on what the physician or practitioner has set up for their plan. Okay. Now, the different treatment therapies, we're going to manage it in a non-prescriptive or medication type regimen, but also the medications are going to play a big role here. Okay. The bronchodilators, we've got short and long-acting bronchodilators. These are going to be more along the lines of your rescue type drugs. Okay, the short and long-acting beta-2 agonists, particularly the short-acting, your albuterol, Zopanex, things like that. You've also got your cholinergic antagonists or anticholinergics. You've also got the methylxanthines. Okay, these are the fillings. These relax the bronchial smooth muscle. They help to dilate the smooth muscle. Then you've also got your anti-inflammatories. You've got your corticosteroids. NSAIDs, some use them, some don't. Why do you think NSAIDs are kind of hit or miss? Yeah, I mean it's pretty closely related to aspirin, right? It could be a trigger in some patients. NSAIDs could directly cause or impact, or at least make the risk worse of having an asthmatic attack. Some patients it actually reduces the inflammation, some it doesn't. So it just depends on the patient there. Okay, corticosteroids, we've got Pulmicort, Flovent, the leukotriene antagonists, we've got Singulair. These are your maintenance drugs. Okay, these are the ones that they need to take every day, regardless of how well they think they're breathing. Okay. Some of the other treatments for asthma include exercise and activity, remote ventilation, and perfusion. Okay, now it's got to be done based on the patient's tolerance. Okay, because what could we do with increasing exercise and activity to a certain level? We could cause the attack. We don't want to do that. Okay, but we kind of want to build up that tolerance as much as we possibly can. All right. We don't want to tell an asthmatic patient, well, you got to sit on the couch all day and you can't do anything. Right? There's a balance there. You're going to balance it out. Oxygen therapy may also be needed. Okay, via mask, nasal cannula, or an ET tube. An acute asthmatic attack, ET tube is probably going to be the way they got to do if they're in status asthmaticus. Just depends on the patient's condition and how well they are perfusing. We're talking about status asthmaticus. Is a severe life-threatening acute episode of airway obstruction. Okay, it intensifies once it begins and often does not respond to common therapy. The patient can develop pneumothorax and cardiac or respiratory arrest, and the treatment is going to be with IV fluids, potent systemic bronchodilators, steroids, epinephrine, and oxygen. Now, say the patient comes in, you've had an asthmatic patient, or you get a call, you're admitting in the ER a patient in an acute asthma attack. Well, when you get them, they're not really responding to you. Okay, maybe they're responding a little bit, but they're definitely lethargic. Okay, so you go and you listen to their breath sounds. There's not much going on. Okay, what could this indicate? If you've got breath sounds, now they're not even wheezing. What could this indicate? Yeah. You've got some kind of obstruction that now, not only are they not, they're limited in their movement of air, but they're not moving air at all. Okay? In this case, the only treatment, you're not going to grab oxygen, you're not going to grab a bottles cart. You're not going to worry about oxygen sats at this point. At this point, you've got to get them ready for intubation. Okay, you got to secure an airway, because at this point they do not have the airway. Okay, very, very important. You've got to be able to recognize the difference between, they're in an asthma attack and they're to the point we've got to get them intubated, and we've got to secure an airway. Okay, it absolutely will. But the key is, the longer it goes, the harder it will be. And it may be that they end up having to do a trach. They may have to secure an airway another way. But as a nurse, you need to be able to recognize, hey, this is not just a typical asthma attack that we can give them some oxygen, give them some bronchodilators, give them a breathing treatment, and they improve. We've got to do something to secure an airway, or all these other methods are not going to work anyway. Okay. All right. So that's status asthmaticus. Just recognize the differences between those two. All right, now COPD. Okay, I know you've all heard of COPD. You've probably taken care of patients with COPD. It's pretty common now, right? COPD is two different things. Or, well, it's not two different things, but there's two separate issues that are combined into one. You've got emphysema. Okay, emphysema is going to be a problem at the alveoli level. Okay. Chronic bronchitis is the second part of it, and it's an airway issue. It's the airway inflammation. All right, COPD is going to be characterized by bronchospasm and dyspnea. And here's the key distinguishing characteristic between COPD and asthma. The tissue damage is not reversible. It increases in severity and will eventually lead to respiratory failure. Okay. Now, asthma was what? Reversible and intermittent, right? Now, there are exacerbations of COPD that kind of come and go, but it's not reversible. Okay, this tissue damage that occurs, basically you're killing off the alveoli. That's the emphysema part. You're damaging the tissue from the alveoli level where gas exchange occurs. So that's the emphysema aspect. Okay, and you've also got the airway obstruction due to the bronchitis. And this is basically just saying that. Okay. Another distinguishing characteristic on the asthma side, you don't have the tissue destruction. You don't have the alveoli problem. You've just got the airway problem. Okay. All right, so emphysema is loss of a lung elasticity and hyperinflation of the lung. Dyspnea is the result, and also increased respirations. The patient has to increase respirations to be able to oxygenate the patient, or well, to be able to oxygenate the blood effectively. Air trapping is going to be caused by loss of elastic recoil in the alveolar walls, which causes overstretching and enlargement of the alveoli into the bullae and collapse of the small airways. Okay, the key is you've got damage in the alveoli due to this overstretching, and there's no gas exchange occurring. So we have reduced oxygenation of the blood, but what do we also have? What else happens in that gas exchange process? CO2. Yeah, we don't get rid of the CO2 either. Okay? So we have a buildup of CO2. We also have diminished oxygenation in the blood as well. This is the aspect of it that will lead to decreased CO2 sensitivity. Why is sensitivity to CO2 important? Yeah. That's the way your brain knows, let's adjust these respiratory rates. Let's adjust it so that we can change this pH that's now, hey, we've got to build up a CO2, and our pH is doing what? It's falling into acidic levels. So the brain recognizes, in a normal patient, recognizes that increased CO2 and that change in pH, and it increases the respiratory rate to blow off some of that CO2 and bring it back to normal. This is a respiratory problem. So if you've got respiratory acidosis, this is one of the causes of respiratory acidosis. Okay? Due to this trapping of the CO2 and inability to get it out. So that's emphysema. Now we've also got the chronic bronchitis aspect of it. Chronic bronchitis is inflammation of the bronchi and bronchioles caused by chronic exposure to irritants, particularly cigarette smoke. It's characterized by inflammation, vasodilation, congestion, mucosal edema, and bronchospasm. So we got fluid buildup in the bronchioles. Okay. This aspect affects only the airways, not the alveoli. The chronic bronchitis is not affecting the alveoli, but it's affecting the ability to breathe in and exhale out. Okay, and as a result, we're going to have a production of large amounts of thick mucus. A lot of mucus buildup, and it's thick mucus that, in a lot of cases, it's hard to get it out. All right, so some of our complications. Hypoxemia and tissue anoxia. All right. Acidosis, we talked about that. Respiratory infections. Patients more likely to get these respiratory infections. And it makes it worse. Makes the COPD worse. Cardiac failure, especially the cor pulmonale. What's cor pulmonale? I know y'all talked a little bit about that, right? What's that going to be? What's it putting pressure on? It causing. All right, it's pressure buildup in the lung vessels that supply blood to the lungs, right? Or, well, not supply, but bring it back to the lungs for oxygenation. So what is that putting pressure on? No. The left side, it's going to go to the left side, but where's it putting pressure on if you've got a buildup of pressure in the lungs? Pushing back on the right side. So the right side's having to work harder to overcome that increased pressure in the lungs. Okay? So cor pulmonale is right-sided failure. Okay? Yeah, I mean, it results in the right-sided failure. All right? And also cardiac dysrhythmias. Okay? And this is kind of a direct result there. Cardiac dysrhythmias as well. All right, so our assessment and clinical manifestations, well, for one, we got to get a good health history. Assess the general appearance. And what are some of the general appearance changes? I know we've talked about some, but for a COPD patient, chronic respiratory insufficiency. Okay, clubbing of the fingers. Okay, barrel chest. What else? Poor skin color, paleness, maybe cyanosis, depending on the severity. Now we got the barrel chest. What else are we going to have in their physical body structure? Okay, maybe in the tripod position, right? Because what are they doing? They're trying to open up the diaphragm as much as they possibly can. Okay, so yeah, they're bigger up here. They got the barrel chest. But what happens to the arms and legs? Yeah, they're deprived. Everything else is, all the nutrients are going to the respiratory system and the respiratory muscles that control it. Arms and legs are going to get thin. Okay, very thin legs and arms. Okay. All right, respiratory changes. What respiratory changes might we see? Okay. Increased respirations, absolutely. Okay, decreased O2 sats. Yeah. Now, on just a normal basis, this may be their baseline O2 sat of 88, 90%. You know. Okay, we talked about the cardiac changes. It's putting extra pressure. If the heart is having to work harder, what's happening? Or as a result, where are you going to see effects? Everywhere. The left-sided failure can't keep up, you're going to see pulmonary congestion, which makes it even worse, right? Okay, pulmonary congestion, putting more pressure on what? The right side. The right side. When we have issues with the right side of the heart, where are we seeing the signs? To the body. So the patients are going to be swollen. Now, depending on the condition and the level of exacerbation. So these thin extremities may become swollen, right? That's a big change. A patient that normally has really skinny legs and then now they're blowing up like crazy, you got a lot of issues going on now. All right, so that's the cardiac issue. Again, I've showed you this, I think, the first week, but dyspnea assessment tool. This is kind of just put a mark on where your dyspnea is today. Walk in the room, okay? Give you a line. I'm good. I'm not having any breathing problems. To now, I can't even say a word without having the dyspnea. Put a line on it. And then these classifications. I'm not going to go through each one of these, but class 1, everything's good. Class 2, we're starting to have some issues on normal activity. Okay, walking up the stairs, trouble breathing. Once we get to the top of the stairs. Okay, class 3, now we are having issues even with getting a shower. Maybe we eat and start having some trouble breathing at the end. We don't necessarily require a lot of help yet, or direct help yet. But we're starting to get there. Class 4, yeah, we need help. Okay, changes in ADLs. I can't get myself dressed. I can't really take a bath without having somebody there to help me. All right, and then class 5, we're entirely restricted. We don't have any. There's nothing. These main issues we can't just go. We really can't even go out of the house in most cases. All right, lab assessments. Okay, lab assessment. We're going to look at ABG values as much as we can. Now, is this going to be our first test? These ABGs. They're pretty painful. It's a pretty invasive test. If a patient's in an exacerbation of the COPD, or really struggling to breathe, the physician would possibly order it, but it's not going to be their first test. We do look at sputum samples as well. We've got CBC levels. All right. We want to see that ability to move the blood to the tissue, or not even the blood, but the oxygen to the tissues. Hemoglobin and hematocrit levels, self-explanatory. We got the hemoglobin. We've got to have those, and at good levels to be able to carry the oxygen. Serum electrolytes, serum AATs. Serum AAT is going to be antitrypsin or alpha-1 antitrypsin. Increased levels are going to indicate presence of acute chronic inflammatory markers. Also an indicator of stress, infection, and possibly thyroid issues. All right, but they could be up, or they could even be down with the presence of emphysema. So that's not necessarily the best marker. It could go up or down, but they will evaluate. Chest X-ray, we want to evaluate the structure and function. We want to evaluate the ability of the lungs to expand. Are the lobes nice and open? Lungs nice and open to be able to fill with air. And then also our pulmonary function test we talked about before. Evaluate that ability to expand and then contract. What's the volume? What's the vital capacity there? And then our interventions. Our interventions are going to be to improve oxygenation and reduce CO2 retention. Place the patient in an orthopnic position. Anybody know what an orthopnic position is? Okay, up. And what do we do with it? How do we help to position them up? Raise the head of the bed, put some pillows behind them, get them in a good breathing position. Okay, they're struggling to breathe, just sit them up. Okay. All right. Also, prevent weight loss, ensure adequate nutrition. How can we've got a COPD patient that struggles to breathe, any kind of activity. With this patient, how can we help to prevent nutritional deficits? right, offer them things that they like to eat. That's good. What else? What type of foods would we recommend? High calorie, high protein type foods. Okay. When are we going to offer them? Yeah. What we're going to do, we want to do small meals more frequently. Okay, so frequent small meals. If they have trouble breathing while they're eating, but we only give them food 3 times a day, they may try to overexert a little bit, and then they have, then they feel worse afterwards. So they may end up not even eating at all because they know they're going to feel bad. If we give them just smaller meals, they can tolerate it a little better, and then we can, kind of encourage that intake. Anxiety, again, we've talked about. You can't breathe, you're going to have some anxiety, right? Minimize that as much as possible. Treating the underlying issue helps with that, but also try to help with relaxation techniques. Try to calm them down the best you can. Activity tolerance. How can we improve activity tolerance? Okay, small periods of exercise, absolutely. We're not going to try to work them out, again, all at once, right? How can we alter our nursing care to improve their activity tolerance throughout the day? Take the care up, okay? They've eaten breakfast, and now we want to brush their teeth right after, right? We want to get it all knocked out, And it may be, you may have an aide. You may tell the aide, hey, look, give them an hour and a half before you go back in and do teeth brushing. Then go back another 30 minutes before you do a bath. They don't have to do everything right there first thing in the morning. You may have to alter. That's a nursing implementation there. Okay, you can choose how things are done to a certain degree. Break them up. Help with that. And then also prevent respiratory infection. Everything we do, we're trying to prevent infection as much as we possibly can. We don't want to make it worse by causing another infection. All right, some of the drug therapies. Let's see. Did I skip something here? Oh, there we go. All right, so these are going to be similar to asthmatics. Similar medications. We're not really altering that as much at all. We still got our beta-adrenergic agonists, beta-adrenergic agents. We got the albuterols, the Xopinexes. Now, what's the key here? Okay, we've got a beta-adrenergic agent. What is that doing? Okay, is it blocking? It's stimulating. So beta-adrenergic agent is stimulating the beta receptor side. Okay, what else do we do to alter these beta receptors? We give beta blockers also, right? And what do beta blockers do? They kind of decrease that cardiac strength of contraction. They do what else? What else do they do? What's the result? Blood pressure does what? Decreases in blood pressure. What happens to heart rate? Decreases in heart rate. Okay? So if we're giving a beta-adrenergic agent, what are we doing? We're stimulating, we're doing the things we're trying to do. We're trying to open up the airway. We're trying to, help us breathe a little bit. But on the backside, we're also causing the same cardiac effects that we're trying to prevent on the other side. We're causing the increased heart rate. We're causing the increased blood pressure. So you got to be careful with those. All right, so albuterol, you got to definitely be careful with that. If you've got a COPD patient that has blood pressures of 220 over 110, do we need to give that albuterol? You got to kind of weigh the pros and cons there. Make sure that the physician has, hopefully, he's got some parameters. We may have to look for some other options. All right, so our cholinergic antagonists, or anticholinergics, got Atrovent, Ditropan, Cogentin, methylxanthines. We got our phylline, such as theophylline, helps to relax some of that bronchial smooth muscle. We got our corticosteroids, Pulmicort, Flovent. Again, these are the same medications that we give to our asthmatics because we still have some of the same issues. Mm-hmm. Yeah. Very common. I mean, that's very common. And yeah. And yeah, because I mean, if you've got a yeast infection in your airway, is it making it easier to breathe? Probably not. Probably not. And also with those same types of things, our corticosteroids. What do steroids do? What are some of the side effects of steroids? Okay, they suppress the immune system. What else do they do? Make you gain weight. Yeah, what else? What are they going to do to our vitals a little bit? Jack them up too. Okay, you may have some increased blood pressure and heart rate. What happens to our blood glucose? Blood sugars go up. They shoot through the roof sometimes, commonly with these steroids. So these are kind of things you need to consider. You got to treat it. Airway comes first, so we got to treat that first. But there's different methods for doing that. Then we've got the NSAIDs again. Be careful. Make sure they're not causing some more airway hyperresponsiveness. But it does help with inflammation at times. And then the mucolytics. What are our mucolytics? What do they do? Thin the mucus and help to bring it up. Okay. All right. There are some surgical management strategies. These are not going to be your first treatment options. Or not yours, but they're not going to do these first anyway. Lung reduction surgery. Why do you think lung reduction surgery may help? If we've got a lung with emphysema, okay, a lot of damaged tissue, what is that doing? That's just space we're bringing air in, but we're not really able to exchange gases. We're not really doing anything with it. It's basically wasted tissue. Okay, so we'll actually go in and take away some of it, some of that extra dead tissue that's just making things worse. Okay, causing that air trapping and increased CO2 levels. You don't have to know necessarily all these different procedures. Just be aware of some of the things that they're doing here. The preoperative care and testing. What are we going to do pre-op? Really for any procedure. Blood work, okay. History, make sure you got a good history. What do we need to make sure is done before they go in? A consent. Okay, what else? Make sure they don't eat or drink. Absolutely. I mean, these are the things that you've got to do as a nurse or make sure are done prior to the procedure. Okay. Some of the other operative procedures they can be done by median sternotomy or VATS procedure. These are just the methods that they go in. The key here, we've got post-op care. What are you going to monitor post-op? This is the most important thing on this whole page. Airway. Absolutely. When they come out, what are we looking for? Airway. Signs of respiratory distress. Signs of insufficiency. Okay? And then we've moved out of our airway and breathing. What are we looking at? Circulation. Make sure that's good. What else? After that? Yeah. Incisions. Infection. Pain. Absolutely. All these things that you typically do in your operative sections that you talked about, it's the same with our COPD and our respiratory type surgical patients. Okay? And our dyspnea management, we talked about this, offer periods of rest before meals, 4 to 6 small meals a day, and community-based care. This is kind of talking about your education, discharge teaching. You've got to make sure that the patient knows how to use their oxygen. Okay, if they're going home with oxygen, which we try to keep COPD patients off of oxygen as much as we possibly can, but when they have to have it, they may go home with it. What do we need to know? Make sure we teach the patient before they go home with home oxygen. Yeah. Can cause combustion. Okay. So no smoking with the oxygen. You know, yeah. How to use it. Make sure they're using the correct amount. They don't need to. If the doctor's ordered 2 liters, they don't need to bump it up to 6. Okay. Mhm. Mhm. Yeah, and it's because of the you got the emphysema. Again, it's a progressive disease. It'll eventually cause that respiratory failure, and it's just a progressive disease. Well, they become, and it's they're resistant to come off of it. It's hard to get on. Once they get on it, it's hard to come off. Once these patients get on a ventilator, it's hard to wean them from that ventilator. They become dependent on it, and they lose that CO2 recognition of the brain to increase the respirations. They lose the ability to alter those processes. Pulmonary rehab programs may go in. These are our patients that maybe go to a rehab facility to kind of improve that exercise or activity tolerance, improve the ability to care for themselves as much as possible. Depends on the patient and condition, obviously, but those are commonly used for our COPD patients. We want to teach self-management as much as possible, including drug therapies. How many of you have taken care of a COPD patient, maybe in a clinical, or how many medications do they typically have? A lot. And it's not all just related to COPD either, is it? Commonly diabetics, commonly, you may have 15, 20 medications. In your experience, how hard is it to take care of a patient and accurately give them 15 to 20 medications? It's easy to miss one. It's easy to give one at the wrong time. Now you're talking about patients that are already have some chronic issues going on. Maybe they're older. So how hard do you think it is for them to give themselves the medications accurately? Even bigger. I mean, it's dangerous. It's dangerous for them to be on that many medications a lot of times. So, you got to make sure that you teach them the importance of what does this medication do. Make sure they know the regimen, and not necessarily just by color. Because you'll say, well, I take 3 of those blue ones, or I take 2 of those white ones. But you got 15 different medications here. And maybe you go to the pharmacy and they give you a different type of the medication. Yeah, they don't like it at all, do they? So you got to kind of teach these patients a little bit, as much as possible. Make sure they recognize manifestations of infection, which is extremely important for COPD patients. They need to recognize the early signs of infection, because what could happen? If the infection progresses, sepsis, but it's going to directly impact that COPD patient's ability to breathe too, right? It's going to cause that exacerbation. If they recognize earlier, they can get to the physician's office, maybe get some antibiotics, maybe get some treatment options or treatments before they get to that level where they have to be hospitalized. The different breathing techniques, we've talked about the pursed lip breathing. Okay. What else? Any others that you can think of? Absolutely. Breathing in through their nose and then out through their pursed lips as much as possible. Okay. When they're having those difficult periods of breathing. All right. Help them know. If you're, it's natural, but if they're laying flat and they have trouble breathing, let them know. Hey, sit up. Make sure that they sit up after meals and during meals. Don't let them get lazy to where they're not wanting to sit up and eat. It causes aspiration and all kinds of other issues. Okay.